Okay. So thank you so much for being here, Sheldon. Sheldon Cheskes is a very important researcher from Toronto, Canada, and he had a lot of papers on cardiac arrest and trauma, and in particular this paper published on the New England Journal of Medicine, I think is very interesting because could change dramatically our clinical practice. So thank you again for being here, and please, thank you.
Thank you so much, and really a pleasure to speak to you, Jojo. I know when um, I had your invitation, I was very excited um, with the for it to present in Milan. I would love to be there personally, to be honest with you. And I think we're going to be in Milan in the summertime, so maybe I can catch up with some of the residents and they can ask me any question they want. So I'm really thrilled to be able to speak to you folks today, and hopefully you take a lot out of this particular talk. So my talk obviously be on the DOSVF cluster RCT. The following is my disclosure slides. As well, here's my research funding slides. Um, for me, we always acknowledge all my sort of co-investigators, and many of them are well known to resuscitation science. But for me, the most important people in this study were the paramedics that were trained in the study. We trained 4,000 paramedics in the DOSVF study. And in all my time as a resuscitation scientist, I don't think I've ever had a time where paramedics embraced the study as much as they did the DOSVF study. They were just phenomenal in this particular study. If I had my own way, these would all be co-investigators in the study. The paramedics were that special. So I think the question for folks is really, why is there so much interest in the concept of refractory ventricular fibrillation? With our study today, with our study in November, we bring interest in the idea of alternate defibrillation strategies. Many have done research, both observational and recently some smaller randomized trials on the concept of ECMO for refractory VF. And I think the reason there's so much interest in refractory VF is simply the survival and the numbers. And when you look at this, and this is work very similar to the work that we've done here in Toronto, this is from a Swedish registry, 20,000 patients over 25 years. What you'll see is that the survival from cardiac arrest.
Sheldon, sorry, we are seeing just the first slide. Have you gone?
Yeah. No, I'm on slide 7 already.
No, we can see only the first slide.
Oh my God.
Okay,
Oh
so
my God.
you were very clear, so it was okay for, even if we didn't see the slides. And if you will come to Milan, it will be a real pleasure to help you to find places and so on, and to have you here.
Yeah, but it's going to be very hard to see if you can't see my slides move.
Yes.
So I'm going to try this one more time. There's something I've done this talk 100 times.
No, do you want to send to me the slides, and I present the slide when you speak? Can we try?
We can try that. It's a little bit harder for me to do. I just don't understand why that is happening though. But again, I think it's Teams. I've never had a good time with Teams. So if you want, I can send you the slide deck.
Yes. Do you share are you sharing your PowerPoint file or your video?
No, there's no video. This is all on PowerPoint.
No, yes, but your monitor or the PowerPoint, because maybe you can try to share or your monitor or the PowerPoint slide, and maybe it works better in one of the two way. You understand? Or you can send to me, and when you say go to the next slide, I will go to the next slide.
So are you seeing my slides right now?
Yes, the first one.
Okay. Are you seeing my slides now?
Yes, the first one.
And how about now?
The first one.
So nothing is moving.
No.
That's really strange.
Because I don't.
I'm gonna try something different here. How about now?
No, the first one.
Now?
The same.
It's the first one.
Yes.
Wow. That is very odd. So I'm very sorry. I'm not sure what to do here. I can send you my talk. I hate to keep going next slide, next slide. I've never really
Yes.
done this before, and it takes a lot of the pleasure out of giving a presentation, but I can try to email you my slide deck.
Yes.
Let me try to do that now, I guess, and then we'll try to do it that way. I don't know how I'm going to see the slides though, so just give me one moment here.
Yes.
I'm so
Or do you
sorry.
want to try to go away and come in later to try if there is the connection?
No, just give me one moment. I'll try to
Yes.
send you the slides and then we can go from there.
I'm not sure I understand.
I have to find your last email now, Giorgio.
Yes, is if you want is Giorgio or I can.
I think you sent me an email yesterday.
Yes, but I will send you an email now, just now. Okay.
Here, I got it, Giorgio. I got
Okay.
it.
I'm very sorry. Usually you use Zoom or.
Yeah, I usually use Zoom. So I just sent you my slides. So let's see if they come and then we can go from there.
Yes.
Sorry, folks. I was so looking forward to this.
I'm very happy because it was for someone, the link was at 5 o'clock. So this is just the people
Oh,
will
so
be very
they
happy. So
they may be able to make it now.
the slide arrived.
Have those slides arrived, Giorgio?
Yes.
Okay. We could be in business.
And I will try now, maybe.
Yeah, the whole fun of the talk is seeing the slides.
Do it is can you see this?
Beautiful, Giorgio.
Is okay?
Okay. Can everyone see them there?
Okay.
Okay, very
Yes.
good.
Yes.
Okay.
Good.
So
Yes,
what we'll
Okay.
do is let's see if we can start from the beginning then. Is that okay?
Yep.
Giorgio, do you want me to start from the beginning or where we left
Yeah.
off?
Yes. If you can, it's better maybe from the beginning.
Okay, fantastic. So again, thanks so much to everyone for allowing me to present today to the University of Milan residents. As I said to Giorgio in my previous talk, I hope to come to Milan in the summertime. So hopefully some of the residents or staff can show me around. So we're going to talk about the dose-VF cluster RCT. Next slide. The following is my disclosure slide. And next slide, Giorgio. and my grant funding slide. Next slide. So in this study, you can see that I obviously acknowledge a large number of my co-investigators, many of them well known to the world of resuscitation science. For me, though, the most important people in this trial were the 4,000 paramedics we trained in the dose VF RCT. I've never in my career as a resuscitation scientist seen a study that was so embraced by the paramedics. And without them, this would never have happened. As far as I'm concerned, I would have them all as co-investigators in this study. So a huge shout out, as I will do many times in this talk. So next slides, Georgia. And the question really remains, so why is there so much interest in the area of refractory ventricular fibrillation? Next slide. We know our study really focused on alternate defibrillation strategies for ventricular fibrillation. Many have done some work in the area, both randomized trials and observational trials on the use of ECMO for patients in refractory ventricular fibrillation. So why is there so much interest in this area? Next slide. And I think the issue really goes to survival in VF in relationship to shock numbers. So if we look at this particular slide, you'll see, and this is really slides 20,000 cardiac arrests, Swedish database, 25 years of data, very, very similar to our research database. And what you'll see here is that when you look at shock number and survival, really tends to fall off a cliff when you look at patients after the first 3 shocks, which is very similar to the ECMO trials and dose VF. And you'll see that survival rate of about 12.7% for people who get 4 to 10 shocks, and obviously very, very low at people with greater than 10 shocks. So the focus for us was, could you actually improve survival in this group that gets 4 to 10 shocks and make it more consistent with those who get 1 to 3 shocks. So the panacea for a long time has been the concept of standard defibrillation. So if you go to the next slide, Giorgio, what you'll see here is it's excellent. You know, with biphasic defibrillation, I think we figured it all out. Everything was solved in ventricular fibrillation when we figured out biphasic defibrillation. And the reason is, you look here, and the VF termination rates with standard defibrillation are actually not bad. But if you go to the next slide, Giorgio, the trouble with standard defibrillation is the rate of refibrillation is actually higher than the rate of VF termination. So when we terminate VF, most of the time with standard defibrillation, the vast majority of these patients go back into VF. In my opinion, that's not effective defibrillation, and that's why the thought of alternate strategies has come to the forefront. So that's the background as to why there's so much interest in this area. So next slide, Georgia. So the background for our particular study was, as you've seen in these previous slides, many patients remain in VF after multiple defibrillation attempts. Both the concept of double sequential and vector change defibrillation have been proposed as alternate strategies, yet up until this time, no high quality evidence existed to support or refute the use of alternate defibrillation strategies. And prior to the actual guidelines coming up in the future, there was no support for the use of double sequential under the current guidelines. Next slide, Georgia. So the research question that we had was, among adult patients presenting in refractory VF during out-of-hospital cardiac arrest, does double sequential or vector change defibrillation result in greater rates of survival to hospital discharge when we compare it to standard defibrillation? Next slide. The study itself was relatively complex, a 3-arm cluster randomized trial with crossover. It took place in 6 participating EMS agencies in Ontario, Canada, and ran for just over 4 years. The trial was paused for 6 months due to COVID in 2020, and the DSMB recommended halting the trial in May of 2022 due to COVID-related challenges at our participating services. The primary outcome of the study was survival to hospital discharge, secondary outcomes of ROSC, VF termination, and neurologically intact survival with an MRS score less than or equal to 2. Next slide. I think what's really important for this particular study is really the fact that we did a three-arm study focusing on both vector and energy, because what we wanted to understand, if any of these were effective, what was the biological plausibility of why vector or DSCD would be effective? Is it vector? Is it energy? Or is it perhaps a combination of those two factors? Importantly, to be included in this trial, patients had to present in VF or pulseless VT. They received standard ALS therapy if available, and they had to have a minimum of 3 successive shocks given and be in VF or pulseless VT at the fourth rhythm analysis. So these patients had to go VF, 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 and still be in VF at the fourth rhythm analysis. Anything otherwise, so VF, VF, PEA, VF, PEA, VF, all those were excluded from the trial. We wanted the most refractory patients in this trial. For these first 3 shocks, the pads were placed in the standard AL position. Services were then randomized to one of 3 strategies. Next slide. The first strategy was continued defibrillation and care with the pads in the AL position. Next slide. The next strategy had patients have their AL pads removed, have AP pads placed, otherwise known as vector change defibrillation. Next slide. And the third strategy involved the bringing to the scene a second defibrillator, pads placed in an AP position, and sequential shocking from 2 defibrillators, otherwise known as double sequential external defibrillation. Next slide. In terms of training, we trained all our paramedics, so both ALS and BLS paramedics received standard in-person training on both vector change and double sequential defibrillation. All the cases were reviewed by the local PIs with feedback given to the paramedics on study compliance and protocol performance. So this is, I think, one of the other areas why the paramedics so love this study is their close interaction with the PIs. Next slide, please. From a sample size calculation, we assumed a baseline survival in standard care of 12% with a hypothesized 8% minimum absolute increase in the vector change in double sequential arm. Based on 6 clusters and an intra-cluster correlation of 0.01, we estimated a sample size of 930 with a power of 80% and an alpha of 0.05. Next slide. All patients were analyzed based on intention to treat, general linear models with log link and binomial distribution accounting for clustering of patients within each service. We adjusted for age, sex, and bystander CPR, and the outcomes were reported as adjusted risk ratios with 95% confidence intervals with standard defibrillation as a reference. Next slide. If you look at our consort diagram of our study population, you'll see that we assessed 450 for eligibility. In the end of the day, 405 patients were enrolled in the study, equally distributed between vector, standard, and double sequential, as you would expect. 88% of the patients received the randomized allocation defibrillation strategy, which we thought in a pragmatic trial was excellent given the complexity of the trial in the field. Next slide. What you'll see here is that the vast majority, I hope, I don't know about this in Milan, but in Canada, the vast majority of patients in refractory VF are males. Almost 85% of the patients in this study were males. And that actually, when you think about it, makes sense. Males tend to have larger chests, bigger hypertension, cardiomyopathy, LVH, all those ingredients which generally make standard defibrillation less successful. So transthoracic impedance is really critical, generally larger in males. What I love from a personal point of view, from a resuscitation scientist point of view, are the high rates of bystander CPR. When we started my research in this ages ago, our bystander CPR rates were in the 30% range. You can see how high they were here, and again, nicely distributed between the 3 groups. One of the concerns people always had about this trial is, could you do double sequential and vector change in the field and maintain CPR quality? So next slide. What you'll see in this particular slide is regardless of the arm the patient was randomized to, the patients got guideline compliant CPR quality regardless of the intervention. So we were able to do vector, do double sequential, but still maintain high quality CPR. And I think that's critical. Many times in resuscitation, we may have an intervention that looks great, but if the CPR quality is poor, that intervention may not be successful in those particular patients. Next slide. What you'll see here in the event characteristics, the amount of epinephrine, amount of antiarrhythmic, time to epinephrine, time to antiarrhythmic, all these variables were very similar across the three groups, as again, one would expect in cluster randomization. You'll look at the number of shocks to first ROS, and you'll see them very similar in all three arms, but remember, those randomized to vector or double sequential had to have a minimum of 3 failed standard shocks before getting double sequential or vector change. So you can see here, it only took 1 or 2 vector double sequential shocks to get ROSC in those patients who obtained ROSC. So these weren't patients who were getting a large number of vector double sequential shocks. In fact, it was the exact opposite. Next slide, please. And what you'll see here for the primary and secondary outcomes, you'll see that survival to hospital discharge in the DSCD arm was 30.4%, 21.7% in the vector change arm, and 13.3% in the standard arm. Similar results in terms of superiority were no adjusted analysis. So let's look at the next slide. When you look at the adjusted analysis, what you'll see is double sequential was superior to standard therapy for all primary and secondary outcomes of the trial. Vector change was superior for VF termination and survival to hospital discharge, but not neurologically intact survival. Next slide. This is the first ever RCT exploring defibrillation strategies for refractory VF. Double sequential, as you notice, was superior to standard defibrillation for all primary and secondary outcomes. Vector change was superior for VF termination and survival to hospital discharge. The important thing, and we'll talk a little bit about sensitivity analysis, double sequential's findings were very consistent amongst sensitivity analysis, more so than our vector change findings. Next slide. So how do we contrast this? So we have an RCT which seems to contrast previous observational research and really highlights the difference between an RCT and observational research. Observational research previously lacked a control arm with optimized care, lacked a control of timing of intervention shocks. Generally, previously, DSCD was performed as a last-ditch effort when everything else fails, classic resuscitation time bias. And I can tell you in resuscitation, if you wait till everything else fails, you will also fail. And I think it's really key that we protocolize the care of patients to receive the intervention early in their resuscitation. In the past, there's been a lack of consistent technique to perform DSCD, and no study previously gave any measures of CPR quality while performing the intervention, something that's very different in our particular trial, where we demonstrated high quality CPR as well. Next slide. The strength of our study is in our feelings. It's our cluster crossover RCT design, high quality CPR regardless of the intervention group. We included patient-important outcomes with almost complete outcome ascertainment and almost no missing data. Clearly, you couldn't blind paramedics, but those assessing the outcomes of survival and neurointact survival were blinded to treatment allocation. We feel the study is highly generalizable. We did it in both rural and urban settings. We used both ALS and BLS paramedics. We use both Zoll and Stryker defibrillators. And very important from the defibrillator manufacturer point of view, there was never any defibrillator damage using our technique of sequential DSCD. And I think that's very important. And I'm going to highlight that as we dig into some of the details. Next slide, please. The limitation of the study is COVID-19. COVID-19 pandemic really impacted participant enrollment in the trial protocol and resulted in early termination as recommended by the DSMB. We do know that early termination has the potential to overestimate effect size, but it's very important to understand the overestimation of effect size for early termination is commonly seen and we'll talk about that. I think it's a very key factor. The findings of the study were consistent as well amongst multiple analysis. Our protocol compliance of 88% is not perfect, but we feel it's excellent for a real-world pragmatic study. At the time of the study, we weren't able to collect ED or in-hospital care, but I'm going to show you some of that today so you can appreciate some of those aspects of care. So I think one thing when you look at these studies results is what is the biological plausibility of why vector or double sequential should make a difference for patients. So we think in vector change, the big issue is the position of the left ventricle. The left ventricle is a particularly posterior structure, and being posterior, next slide, what you'll see is when you do standard AL defibrillation, look at this CT thorax and a really well-placed lateral plat right in the mid-axillary line. Even with that, you miss almost 50% of the ventricle with standard defibrillation. Next slide. When you do vector change defibrillation, look what happens. You actually look like you incorporate a greater proportion of the ventricle that you may have missed with standard AL defibrillation. Next slide. By way of double sequential, we feel that you get a much more homogeneous distribution of current through the ventricle. We also think that the VF waveform after the first shock in DSED is very different than the original waveform and maybe much more susceptible to the second shock given from the AP pad. And also, and we'll show you this in a couple of slides, we saw a classic 15 to 20% drop in the AP pad and the AP pad of double sequential when compared to the resistance or the impedance in the previous failed standard AL pad. So what that tells you, the key to success in defibrillation isn't energy, isn't impedance, it's actually current. And we think that the current actually distributed to the ventricle was much greater using DSED. Let's go to the next slide. So for us guys, this is all really cool. It's really interesting, but that some of the stuff here you can see in New England Journal. What I'm going to talk to you about now for the residents is stuff you can't get out of the New England Journal, and hopefully you'll appreciate some of the complexities of this particular trial. So let's go to the next slide. So first of all, what were the challenges of this study? So I think the greatest challenge of Dose VF was the defibrillator companies, in particularly Stryker. The issue for us was that the Stryker Corporation had a letter out to all their customers that if they did DSCD and damaged the defibrillator, they would not honor the warranty of the defibrillator. Now, that wasn't what the case was Zoll, but was the case for Stryker. And as you could see in my initial slides, 3 of our sites were Stryker sites, 3 of our sites were Zoll sites. So what we had to do is I had to take Paul Dorian, he's a world-renowned EPS physician, senior author on our paper, and me and Paul went to these EMS agencies and said, when we do sequential DSCD, there is no physiological or EPS mechanism by which a defibrillator can be damaged. We had to explain that to the EMS medical directors, and thank God they agreed with us and actually agreed to participate in that study. But if they had not agreed, this study would never have happened. So that was a huge challenge in actually getting the study off the ground. The second challenge is obviously a protocol. So many times you write a protocol, and in a perfect protocol here, you would have 3 shocks given. Shock 4 would be in an intervention shock, would be via vector change or double sequential. But the reality of paramedicine is you're treating cardiac arrest in a ditch, on a bus, in a crowded basement, in a crowded washroom. Sometimes that 4th shock couldn't be a vector change or double sequential shock. A standard shock was given, and that's where you'll talk about some of the crossovers that we'll talk about in an analysis of the treatment received arm. And obviously the challenge of COVID. Listen, COVID stopped 95% of trials that were running in pre-hospital care. I think what's amazing, yes, it did stop this trial, but this paramedics did this trial for 18 months during COVID. And I think that's truly a remarkable performance by the paramedics to do this during paramedic. And so it came to a time when it was no longer feasible. And we'll talk about that in a couple of slides. So those for me were the big challenges in the study. Next slide, please. I think what's really important is a safety factor in this issue around defibrillator damage, right? So in our study, we had no chest burns, no defibrillator damage, no inadvertent shocking, no complaints by paramedic, hospital staff, or patients or family members. In fact, during the trial, we actually had many emergency department and EMS contact us to actually find out how to do DSCD. Next slide. Prior to the study, we actually had published some work in Resuscitation Plus where we surveyed to get an incidence or an idea of defibrillator damage by everyone who had published in this particular area. So clearly you're not going to capture everyone, but we've got a good idea from people who actually had done this work in the past. And next slide. And what we're able to see in our survey of 1,130 cases using DSD in our survey, only 5 cases resulted in defibrillator damage, a rate of 0.4%. In every case was simultaneous defibrillation. Using our technique of rapid sequential DSCD, there has never been a reported case of DSCD damage or defibrillator damage. And I think the defibrillator manufacturers are well aware that it cannot happen doing a rapid sequential technique. The damage, if you look on a per shock basis, was 0.1 to 0.2%. So the idea of damaging a defibrillator, for you to actually have the energy go through the other defibrillator as opposed to through the patient, requires you to hit the buttons exactly at the simultaneous millisecond. For humans, it's almost impossible to do. And using a sequential technique, we also feel it's impossible. It's backed up by our study and by our survey. So I think this is important to take forward for people who are considering doing it. We feel the issue of damage is greatly exaggerated. One of the issues that people talked about is, could your results be explained by differences in in-hospital care? Rates of angio, rates of PCI for patients who had refractory VF. So if we go to the next slide, what you'll see here is that when you look at these patients, so this is a subset of patients who were admitted, so survived a hospital admission, what you'll see is the rates of angio and PCI were very similar amongst these groups. There's no statistical difference in the rates of angio or PCI for patients who actually came to the hospital and admitted or survived to hospital admission. You see the PCI rates, in fact, were probably a little bit lower in the DSCD arm. So clearly, this does not explain the difference in our study results. If you go to the next slide, if we look at STEMI versus non-STEMI, we find this very interesting. So for long periods of time, we feel that refractory VF is almost always caused by an ischemic or a critical lesion. So if you look at these patients, half of them had STEMI, half of them had no evidence of STEMI. For those who had STEMI, they got guideline compliant treatments, high rate of angio, high rate of PCI, high rate of survival. What's interesting is for those with no evidence of STEMI, they got lower rates of angio, lower rates of PCI as one would expect, but their rate of survival was still quite high. And I think the take home for me in this slide is, in refractory VF, no one should give up on refractory VF, because I think the rate of survival, even with no STEMI, is in fact quite high. Let's tease out a little bit the idea of the modified Rankin score, the neurological outcomes. So if we go to the next slide, what you'll see here is that the vast majority, 85% of patients who survived to hospital discharge did so with a modified Rankin score less than or equal to 2. The difference is obviously here, because they all do relatively well, is to get neurologically intact survival, you must survive first. And that's why I think you see the big neurological improvement in the DSCD arm. But if we tease this out a little bit, let's look at the next slide. Look at the proportion of patients with a modified Rankin score of 0, no neurological sequelae in the DSCD group compared to vector and standard care. And the reason to me is you terminate VF quicker, you get less global ischemia, and as a result of that, you have a better neurological outcome. So this is a very interesting slide when you tease through the data. Again, these are things you're not going to see in the New England Journal article. I think you may have noticed when I mentioned the issue about inclusion and exclusion criteria, I said if ALS care was available. And in 8% of the patients in the study, we had BLS only care. That meant no IV, no airway, no endotracheal intubation, no intravenous epinephrine, no antiarrhythmics. And if you go to the next slide, what I think is incredible is that in these patients, so no IV, no antiarrhythmics, no epinephrine, no amiodarone. I need the next slide, please. What you'll see is a 50% survival for patients with BLS care only. And I think what this goes to show is in patients in refractory VF, you can talk all you want about drugs, amiodarone, epinephrine. What makes the difference is actually defibrillation. So I think what's important to note, just need the next slide.
Yeah, sorry, I lost, but here we go.
So I think the interesting comment here is this whole concept of refractory versus recurrent VF. So I think it's important to note that in our study, we defined refractory VF in a pragmatic manner that paramedics and physicians would understand. So patient presents in VF and remains in VF after 3 consecutive shocks. And I think this is really important because the EPS physicians amongst us would suggest that the vast majority of the patients in this trial actually didn't have refractory VF. They actually had recurrent VF where they transiently came out of VF and then went back into VF. In the thinking of many EPS physicians, research group is this is not true. Our feeling is that double sequential and vector change. Go ahead. I'm sorry. Oh, no, I didn't need the next slide yet. I just go back to the last slide for me.
No, because I don't know if it's my problem or your problem because I didn't get the 20 last 20 seconds.
Okay, no problem. So if we go back to the last slide, I can, if people didn't get this, this is our explanation of the concept of refractory versus recurrent VF. So in this study, we defined refractory VF in a very pragmatic manner that paramedics and physicians would understand. So that was patients who presented in VF and stayed in VF after 3 shocks, all separated by 2 minutes of CPR. So every time they analyzed, the patient was in VF. Now, from an EPS point of view, there are those that would argue that refractory VF is instead very, very rare. So refractory VF from an EPS point of view is a patient never comes out of VF, whereas the vast majority of patients actually terminate VF for a very short time and then go back into VF, as I showed you in some of our early slides. And the EPS physicians would tell you that if patients are in recurrent VF, defibrillation is not the issue, it's something else, ischemia, etc. Our research group disagrees with this, and we feel that double sequential and vector change much more effectively terminate VF than standard defibrillation. We're going to do some secondary analysis where we're going to look at all 405 cases, look at a second-by-second ECG, and actually be able to demonstrate differences in VF termination permanently versus transiently, which is what you tend to get with standard defibrillation. So stay tuned for that secondary analysis. So if we go to the next slide, I'm going to go through some statistical stuff for people because there was one of the statistical sensitivity analyses that gets people very confused. And I want to go through that for people because it gets our statisticians very excited when people do this. So we were very clear here. We presented results related to our primary analysis and then a number of sensitivity analyses. So here's our primary analysis where you see DSCD and vector change being superior to standard therapy. If you go to the next slide, what you'll see here in a per protocol analysis, so these are people who are randomized to DSCD and vector and got DSCD and vector, you'll see DSCD is still significant, vector changes loses significance in this particular analysis. Next slide. In the next slide, what you're seeing is an optimized per protocol analysis. These are patients who got the protocol exactly as was meant to be. 3 shocks, and then shock 4 was a vector double sequential shock. And what you'll see here, again, double sequential and vector are both significant. Again, highlighting the fact that if you're going to do these interventions earlier is better. So this is a really important slide. And now the slide that throws the statisticians crazy is the next slide, which is the treatment receive slide. So in the treatment receive slide, you'll look and you say, well, double sequential and vector, they're not significant anymore, so the trial couldn't be significant. What I'm here to tell you is that from a statistical point of view, nothing further can be from the truth. The reason you do a randomized controlled trial is to balance variables amongst all your arms. What happens when you look at treatment received is you remove randomization. When you remove randomization, you reintroduce bias, and in fact, you may as well do an observational study. So how could bias be introduced into this study? So if we look at those patients who survived, who were actually treatment received, these were patients who got 3 shocks, and they were in an environment where the 4th shock couldn't be double sequential or vector that they were randomized to. Those patients got a standard shock, got VF termination, and actually survived. So from a treatment received point of view, it favors standard therapy and doesn't favor DSCD or vector change, what they were actually randomized to. If you look at the other side of the coin, those who didn't survive, and this is why the study was stopped by the DSMB, is when Omicron came in Canada, and certainly in Toronto, towards the end of 2021, early 2022, we had a 50% paramedic workforce. Either they were infected with Omicron or they're off on contact. Of those 50%, 95% were sitting in emerge departments on offload delay. So what we had were cases that were randomized to DSCD and vector. By the time EMS got to the scene, fire first responders had already given 6 or 7 shocks. So by the time they were getting DSCD and vector change, you're at shock 8 or 9, exactly mimicking previous observational research, biasing your hypothesis towards the null. And that's the reason the study was stopped, because it was no longer feasible to be able to do early DSCD and vector change, a critical component of the study. So hopefully people with that explanation understand the difference between ITT analysis and treatment received analysis. Let's go to the next slide. In the next slide, some people feel that when you do a study and you do not meet your sample size, that you're underpowered. But people need to understand that power is a combination of sample size and effect size. So if you press the next button, you'll see the estimated effect size here. Next slide. If you see that the estimated effect size in our study was 8%, but the actual effect size was 17%, doubling the actual effect size that was estimated. So in fact, because of the large effect size, the study was not in fact underpowered. In fact, if we did a reverse calculation of the sample size required based on the true effect size, you would need about 250 patients in the study. So just be careful, dose VF itself was not an underpowered study. Next slide. So people often comment on the concept of number needed to treat. So based on our absolute risk reduction, what was the number needed to treat in this study? So next slide. As you see it, so the number needed to treat in the double sequential arm in this study was in fact 6, which is incredibly low. You have to treat 6 patients to prevent a bad outcome for 1 in refractory VF, which is incredible. It's almost the same as ASA use in STEMI. The number needed to treat in the vector change arm was in fact 12. So I think, again, you'll see from a statistical point of view, these are very, very effective interventions. And one of the questions people talk about as well is a concept of survival in relation to shock numbers. So I think one of the concerns that people look at is that the standard arm survival in our study was 13.3%. So people say, whoa, that seems a bit low. But if you look at that slide that I showed you earlier on, survival in the big Swedish group and in our group was 12.7%, very similar to what we had in our standard arm. And the difference is you have to, when you're comparing studies, compare apples to apples, not apples to oranges. So if you look at this next slide, what you'll see here is, again, my original slide here, 12.7%. And again, so people will say, well, Rock Alps in dose VF looked at 2 similar signs that they both looked at refractory VF. Nothing could be the same. Dose VF looked at 3 successive shocks. Rock Alps was 1 shock. So they say that in Rock Alps, the survival in the standard arm was 24.4%. But important, that was after a median of 5 shocks. The median in the standard arm in DSC in dose VF was in fact 7 shocks. So you're looking at something completely different. But let's take a look at dose VF and ROSC survival in relation to shock numbers. So if you go to the next slide, here's what we're seeing as the ROSC rates in relation to shock number. And you'll see the ROSC rates were very high for vector change and double sequential in relation to shock number, drop off as you would expect. But let's take a look at this next slide, the survival rate in relation to shock number. So if we take the dose VF data and look at survival after 5 shocks, similar to Rock Alps, in the standard arm, you're at 35%. Almost exactly the same, actually better than what they actually saw in Rock Alps. So the argument that survival in the standard arm was not up to par does not hold any water. I think what's interesting here is look at the survival in the DSCD arm at shock 4. So if you do it perfectly, you see a really significant benefit. So I think this is alluring when you actually dig into the details. When you're looking at 2 studies, please make sure you look at the methodology, make sure you're comparing apples to apples. Let's look at the slide next in terms of mechanism, because I think this is really cool in terms of the mechanism of DSCD. And we talked a little bit about the concept of impedance. So let's go to these next slides. Let's go to the next slide. This is a classic DSCD case. Really good to see. So again, on a Stryker defibrillator, here's shock 1 pads in the AL pads. You see shock energy, 200 joules, impedance, 103 ohms. Let's go to the next slide. Shock 2, 300 joules, so we do 2, 3, 360, but the impedance almost exactly the same. Shock 3, next slide, 360 joules, impedance 98 ohms. So as you see, for the first 3 shocks, energy increases, impedance stays exactly the same. Let's go to the next slide. So is your first DSCD shock. So the first thing you see is different. These are the AL pads. You see no longer VF, you actually see a return of an organized rhythm. You see the energy of 360, impedance 103. So that AL pad completely consistent with what we see. Let's look at what happens with the AP pad. Next slide. So what you see here with the AP pad, energy 360, look at the impedance drop. A 30% drop in impedance, suggesting that the amount of current going through the AP pad is much greater than what was going through the AL pad. We think this was critical to the success of these alternate strategies. And if you think of it, is this just one case? Let's just look at the next slide. So the next slide here, you look at impedance. These are in the Zoll defibrillators. Look at the vector arm, so that AP pad, big drop off in impedance, similar to the DSED AP pad, big drop off in impedance. And let's see the next slide. When we look at striker defibrillators, you see almost the exact same thing, even a greater drop off in impedance, suggesting current in the AP pad may have had a big factor to play in the success. This is going to be one of our many secondary analysis of the dose-VF paper. Next slide. So people talk about the secondary manuscripts. We are doing a lot of work here. We're looking at the concept of DSED timing. We're looking at AMSA related to being able to pick up STEMI and AMSA based on two different vectors. We're looking at the concept of impedance. We're looking at things such as long-term outcomes of these particular patients, and we're looking at the actual timing of DSED shocks, and actually does that make a difference in these people's outcomes? And people often ask me, next slide, what would dose VF2 be? If there was going to be another dose VF, what would it look like? So I think the only question that remains from a statistical point of view, as opposed to anything other, is in our study, we compared two arms to a standard arm. What we didn't compare, and we would never be powered to compare, is double sequential to vector change. That was not, the study was not powered for that and was not meant to answer that question. So I think if there was an interesting study available to be done, that would be the study that I think would be of interest. And the beauty though is if I put on my Bayesian methodologist hat right now we have informed priors. So we know the survival from DSED, we know the survival from vector change based on our study. In calculating a sample size and power similar to dose VF, with crossover, you're going to need about 1,000 patients to do that study. So that takes a long time in refractory VF. If anyone wants to do it, I'm here to help out, but we in fact are not doing it here and don't have plans to do that particular study. So next slide. So I think the question people are asking is this study ready for prime time? Is this ready for change in guidelines? When I think about prime time and I think about people who are going to look at this particular study, I think it's all about evidence. And I think one of my mentors and one of my co-authors, Laurie Morrison, always told me, when you do a randomized trial, do your best science and let that science speak for itself. In my mind, in the area of alternate defibrillation strategies, there's no better science than what we did in this study. There's lots of you cannot compare observational research to what we did in this 3-arm cluster randomized trial. And to be fair, when we ran this trial, I probably was contacted by anywhere from 50 to 100 EMS agencies who were already doing dose VF or double sequential prior to the study. At least it's good to know that those individuals now have some science to actually back those particular decisions. And as people may have seen, the next slide, the yield core draft recommendations suggest a double sequential strategy may be considered instead of standard defibrillation for adult cardiac arrest to remain in VF or pulseless VT after 3 or more consecutive shocks where the practice is feasible. I think the practice feasibility is important. We think that if you're going to do double sequential, do it like we did in the study. A well choreographed system of care and resuscitation, not just throwing 2 defibrillators on at any time in the resuscitation. Practice it, do it well, do the choreography that needs to be done to carry out the intervention in a successful manner. So next slide. So our conclusion to this particular talk is as part of dose VF, we found double sequential superior to standard defibrillation for all primary and secondary outcomes in the study. Vector change was superior to standard defibrillation for VF termination and survival to hospital discharge. We think both strategies should be considered early in the management of patients in refractory VF. We strongly feel DSED outcomes are much stronger than those of vector change amongst multiple analysis, but vector change should be entertained in signal defibrillator or rural EMS agencies where you can't get
Sheldon.
Next slide.
Sorry, I lost, I don't know if it's my problem. you were on the fourth point.
Yeah, no
The
problem.
SED outcomes were consistent.
Yeah.
Yes, sorry.
Yeah. Yeah, so we were saying, so before you get to the next slide, if people didn't hear my comment, we felt that the findings in double sequential were much stronger than the findings in vector change, and were much more consistent amongst multiple analysis. But we think vector change should be entertained in places where you have a single defibrillator or rural EMS agencies where it's impossible to get a second defibrillator. Next slide. And we'd like to thank, obviously, we wanted to thank the New England Journal for their publication and careful review of our paper. And I'd like to thank the residents of Milan and Georgia for asking me to speak today. I hope you're able to get a great deal out of our talk. I always find this talk so invigorating, because I think it gets people to understand the dose PF trial much better than you can understand in just a simple manuscript. So hope people enjoy that, and I'm happy to answer any questions.
Thank you very much. Just, okay. Is there any question from home? So I will start maybe, but so, no, there is some question already. Luis.
Yeah, morning to everybody. And I'd like to ask to Dr. Sheldon if he thinks with those numbers, if the DSED could become the next standard of defibrillation, even from the first shock in the future, of course, and maybe with more studies.
Yeah, Lewis, a very good question. Excellent question. It's a question we get a lot. My own feeling with the first shock is you have to be very careful because the math changes. And what I mean by the math changes, if you looked at that slide, survival after one shock with standard AL pads is about 60%, 40% after two shocks, about 30% after three shocks. So if I'm designing a study and looking at DSED at shock one, from a superiority study, I need to show my intervention is better than 60%. And it may well be, but my gut feeling is it would take a lot to show that. And therefore, we don't recommend it starting at shock one at this point as well. To do a DSED, you have to log roll the patient. It is a bit of a process where standard AL defibrillation, you just put on the pads. My own feeling is I think standard AL defibrillation is probably okay for the first three shocks. But after that, to me, all bets are off. I think with alternate defibrillation strategies, with ECMO and well done EMS systems, a combination of ECMO and alternate defibrillation strategies, I think there are much better interventions than just doing continued standard AL defibrillation. So I hope that answered your question, but I think it's an important piece. The one area where that may change, Luis, is if technology was developed that could deliver DSED through a single defibrillator. I do think there is technology that's able to optimize the interval. The difficulty from my engineering colleagues in putting DSED into one defibrillator is the size of the capacitors. The capacitors in the defibrillator would have to be very large to be able to allow that to happen. So that could be a challenge, but I think that's the issue currently, in my understanding, of defibrillator technology. So hopefully, Luis, I was able to answer your question.
Yeah, perfect. Thank you. Really, thank you.
You're welcome.
Thank you very much. Are there any other questions? My question is, so is this now the standard of care in Toronto, in your where you work? So now the standard of care is after 3 defibrillation, you start DSED or vector change. Is it?
Yeah. So in Ontario, from a pre-hospital care point of view, all our protocols go through a medical advisory committee, etc. And we are now making the recommendation that this should be changed based on the guidelines, based on our particular study. And this is happening, I can tell you, these discussions are happening all across Canada. In many places I've talked, these discussions are already going on. Either people have already done it or they're moving to that particular change. So I think this will, regardless of what ILCOR, HAERC say, I think there are a lot of smart people out there. They'll read the study and they'll make their decisions for themselves, regardless of what the guideline bodies say. I think there is always a natural hesitancy to change practice based on a single RCT. And I get that. My concern is to replicate dose VF, I think will be a great challenge to anyone. I think it would be a very difficult trial to do with the same rigor that dose VF was done in. But hey, it's a big world. Who knows? Someone may do it. I just haven't heard anyone. And I don't think that agencies are going to hold off making changes, waiting for an RCT. That may never happen.
Thank you very much. I think that the number need to treat of 6 is incredible. Is something is similar to that of pulmonary embolism, the anticoagulation pulmonary embolism. So is very. So my question is provocative. So do you think that it could be in the trial something that could have increase this number? Okay, the fact that the trial was terminated before, but usually this can increase the efficacy of the trial, but when there are some interim analysis and so on in your trial, the reason for terminated before it was the COVID and so on. So I think is a different things. But do you think that something in the design of the trial or in the practice of the trial could have increased the effectiveness of one of the 2 treatments?
Very good. So, Giorgio, that was a fantastic question. And I can tell you right now, people can talk all they want about stopping the trial. Again, paramedics did it for 18 months during COVID. So I think that is a part people should look at. What I can tell you from a statistical point of view, we look for an interaction term between phase of trial and outcome. And what we found, pilot study, pre-COVID, COVID, results were exactly the same. Survival was exactly the same. The survival in each of these 3 arms did not budge across 3 different aspects of the trial. I strongly believe that if we went on with the trial and COVID wasn't there, we would have seen the exact same results. So I don't think that's a statistical analysis, and that's my own feeling. But I think that evidence of running that interaction term and seeing no difference in survival in any phases of the study, to me, that's pretty strong evidence that the trial was very consistent. I think one of the things that people think about is, and we had trouble writing the conclusion to the New England Journal article because we had 2 interventions that were both statistically significant. But I don't think that means that both interventions are equal in efficacy. So even though we didn't compare DSCD and vector change directly, DSCD was much more consistent amongst multiple analysis. The point estimates were much stronger for DSCD. And people need to understand the fragility index for vector change was 1. So what a fragility index is how many patients need to change their outcome from positive to negative for the study to be non-significant. It was only 1 in vector change. That is very fragile. I think I always tell people they need to look at, whenever you see a fragility index of 1, you need to question whether that's efficacy. The fragility index for DSCD was 8, and that's a very, very strong finding. So I don't think, despite what many people may wish to be, because I think there are some out there that feel vector is easier to do, we should just equate the 2. I don't think that's a proper way to interpret the data. DSCD is the stronger intervention. If people ask me, if I have refractory VF, what do I want? I want DSCD. I don't want vector change. But if you have no opportunity and no second defibrillator, then I think vector change is appropriate. But I think it's important to differentiate statistical significance of two findings when the results were really quite different in their magnitude.
Can also ask the people enrolled in DSCD and in ventricular change and in the standard therapy during the same month, was it the same? I mean, because I think that is one of the things that I can imagine that could bias a little bit the trial, but it is not, is if the paramedic was knew which treatment, because it was a cluster randomized control trial, and so maybe he applied the treatment, the DSCD, only in the patient that thinks, but not cognitively, but
I
thinks,
love
and so
Giorgio.
excluded more patients. So my question is,
Giorgio, yeah,
yes.
I love you, man. That's such a good question. So just so people understand, randomization was at the level of the service, not the level of the patient. So we've done plenty of cluster randomized trials in our services. We did them with ROC trials previously. And what this means is cluster randomization. For 6 months, you just did DSCD. So there was no opportunity to do anything else than DSCD. For 6 months, you just did standard. For 6 months, you just did vector change. There was no opening up envelopes or anything like that. For that 6 months, everyone was doing the same thing. And this is very easy for paramedics to identify and very easy for them to do. But I think it's important because it goes to the question of bias. So people say, because you couldn't blind the intervention, was there bias entertained for people to get double sequential instead of what they're randomized to? If you look at the study results, there was not one person from the standard arm who got double sequential instead of standard therapy. That goes to bias. If paramedics were biased, they would have given everyone in standard treatment double sequential. Not once did that happen. And the reason for that is because we stressed it so much in our training. We said, if you want to change practice, you have to run a randomized trial and you have to run it to the T. You have to maintain randomization. And as you see, it wasn't perfect, but it wasn't perfect not because the paramedics didn't want to give the intervention, because the scene didn't allow them to give the intervention. So I think that's really important when you're arguing the issue of bias. And we argued it with ILCOR, who downgraded for bias. We disagreed with that completely. We felt that there was no bias. Even though you couldn't get blinded, we felt there was no bias. In this study, there was a very small number of patients who were terminated resuscitation. So the question is, would you terminate resuscitation more in the standard arm? No, because we didn't allow termination to occur. So that didn't happen. And the reason we didn't allow termination resuscitation to occur is, I strongly believe, no one should die in refractory VF. If you're refractory VF, you should be transported to the hospital if all pre-hospital interventions change, because there are other therapies. Some hospitals have ECMO. Some studies suggest esmolol may make a difference. So there are other therapies that may make a difference. So we didn't want to terminate anything in the field because we still felt that these patients had a chance. And you can see that a little bit from the STEMI, non-STEMI data in their high survival rates. So we argued against, whether ILCOR believes us or not, we argued against the fact that a downgrade should have occurred for bias.
Thank you very much. And my last question, because I would like to when you will come to Milan, I will do many questions. It was very interesting, I think, the slide that the DSCD was most successful at the fourth defibrillation, while ventricular change, it was similar, I suppose, to standard, except for the seventh. Do you have some pathophysiological thought, or do you think it's just the effect of change of chance?
Yeah, it's a great question. I don't think it's chance. I think these interventions all work better earlier. And the earlier you do them, the earlier they're more effective. I think double sequential is a stronger intervention than vector change personally, and I think the study results bear it out. And I think the earlier result is what you saw in that shock number slide. And it was quite alarming when you see the breakdown in shock number. But again, shock number I don't rely on that too much, only because it can be impacted by number of cases, right? So a small number of cases can move that a long way. But you know, the whole study design of vector change of DOSVF was to ensure early implementation of the intervention. And so just so people understand how we did this, patients went shock 2 minutes of CPR, shock 2 minutes of CPR, shock 2 minutes of CPR. Then we then did 30 compressions, 2 ventilations, log rolled the patient, place a posterior pad. We did 30 compressions, 2 ventilation, place the anterior pad. We then did a full minute of CPR and delivered the shock. So what you could see by the CPR quality metrics is that technique of log rolling the patient had minimal effect on chest compression fraction. In fact, we could do that quicker than you can put on a mechanical device, which is you know, really interesting. But all our shock pauses, rate depth, they were all guideline compliant. And we worked for days with our instructors to develop a choreography that would minimize interruptions in CPR, maintain high quality CPR, and I think that came out in the trial.
Thank you very much. Is there any question? So I would like to thank you very, very much, not only because you presented the trial that is very interesting, but also because I think that you presented the trial in a very clever way. So reasoning about possible bias and about how to interpret the trials, and that is exactly what I wanted to have for my residency lesson. So thank you so much. And if you come in Italy and Milan, please tell us that.
I will. My final word to you, to the folks in Italy. First of all, thank you so much. I'm going to be in Cinque Terre. I can't wait to come there because I'm going to go from there to Milan, and then I'm going to go to Lake Como, and I want to go with all my residents here. But what I wanted to give in this talk is give you a sense of what it's like to do a randomized trial, but also get an idea of some of the background that you're never going to get just reading a paper. I don't care if you read the supplement or the paper. It's very hard to understand, get some of these details. And many people, you read a blog, you read this, they're not trialists. So they're not going to give you some of the details that I hopefully was able to give you today, and hopefully will allow you to think about your practice in the future. I think it's really important when you look at science and you get a result that you perhaps don't expect. The question is, do you look at the result, or do you look at your previous interpretation of the science? I think no matter what our biases are, we should always look at science, interpret it in the evidence that is provided, and then always be able to challenge science. And I think that's what DOSVF does. It challenges the dogma of what we've been doing for 30 years, and hopefully people take something out of it. So I thank you so much for your time. I'm so sorry about the glitch that we had there, but I thank you for your time. It was a pleasure speaking to you folks.
Thank you very much, Sheldon. Thank you. Thank you.
Bye-bye, everyone.
Thank you.
Buongiorno.
Bye-bye.